In terms of musculoskeletal presentations, this graph was from a paper from South Korea, really large data set. So I think it was the National Health Insurance data set within South Korea, 16 million people, and it shows this increase in cumulative incidence rates when going from increasing BMI categories, and then also at waist circumference, cumulative incidence rates for Achilles tendinopathy and Achilles tendon rupture from lower third to middle third to upper third of waist circumference, which is particularly clinically relevant. Waist circumference is that's a measure of visceral or abdominal adipose tissue or central adiposity, which we know is linked to unwanted and suboptimal health outcomes, not just musculoskeletal. Then with knee osteoarthritis, which is particularly relevant in relation to living with overweight and obesity, and a favorite topic of mine to talk about is knee osteoarthritis. This is from a large cohort in Spain. 1.7 million people were enrolled as part of this cohort, which the observation period was 5 years. The authors here grouped people based on body mass index by normal or healthy, overweight, type 1 or type 2 obesity. I think it's worth touching on here. Body mass index as a tool for individual use has definitely got question marks around. But for public health, at a population level, that's where body mass index has its uses. And you can see this step-by-step increase in incidence of knee OA based on increasing body mass index. And then we also see that in this cohort from Australia. This was a cohort of 23,000 people in Australia. And the authors here analysed people's risk of or likelihood of requiring a total knee replacement over an observation period where those people whose weight remained the same was the reference. So that was given hazard ratio of 1.0. Those group whose body weight didn't change. Those people who gained 5% or more of their body weight over the study period had a slight, while there's overlap, slight increase likelihood of total knee replacement. And then those people who lost 5 to 7.5% of their body weight, on average, a slight decrease, again, although there's overlap, where we can start to really see quite a significant changes where we get weight loss of over 7.5% of body weight, which other literature would support in the case of knee osteoarthritis is starting to get to a real clinically significant amount of body weight loss for reduced symptoms. The hazard ratio goes from 1 to 6.8. This is quite a significant drop in risk. So we can start just touching on these few studies, can start to clearly see that for a number of musculoskeletal complaints, body weight plays a role. And as physiotherapists, this is something that we should be aware of.